Okay, good afternoon. Call your classmates so we could start in 5 minutes.
Okay po, Tong. Saglit lang po.
23. Ilan kayo? So we could start 1 p.m. Dr. Pineda will start her review, so I don't want to encroach to her time. Anyways, this will be a short review because we will just go through um, important points that you have to know with regards to take to abortion and ectopic pregnancy, and what are the usual exam questions that are asked about these topics, whether it be in seminar or come clerkship and come medical boards. Okay. So, an abortus usually weighs, what's your answer for this question?
Less than 500 grams.
Less than 500 grams. Okay. So for you to be able to answer this types of question, you would have to know the definition of abortion. And how is abortion defined? One definition is your definition by weight. That's correct. 500 grams. What else could be asked when when the question asks for excuse me, the definition of abortion? How else is abortion defined in Williams?
Doc, less than 20 weeks po ba?
Less than 20 weeks. Okay. It sometimes it will depend. So it will be dependent on age of viability. So it is 20 weeks or less than 500 grams. Okay. And it is either spontaneous or induced, whatever the mechanism of action, termination of pregnancy before fetal viability. So those are your definition questions. Of course, there are a lot of ways definition questions are asked, but you should be safe if you know this definition. Okay. So another way of which questions are asked with regards to abortion would be classification. And so it could be an embryonic or embryonic. So there's no identifiable embryonic element. So that is your anembryonic pregnancy, which is also known as your blighted ovum. Of course, your embryonic would contain your fetal parts, often with developmental abnormalities. Okay? Of course, you have to know your incidence. 5 to 20 weeks, 11 to 22% of your abortion would occur, and 2/3 would occur in early pregnancy, and more often, your patient does not know that she is already pregnant. Okay. So coming to a question, most common cause of abortion, knowing the past two slides, what could be your answer?
Genetic, Doc.
So it's genetic. So for you to be able to answer this question, you should be able to know the risk of the risk of abortion according to causes. So your euploid abortions would be your normal karyotype, but 50% will be abnormal. So one of the more common would be genetic, because that 50%, if you will divide, if you go back to the question to the question at hand, your infection, your induced, and your diabetes would share etiology with that 50%. Your genetic would be purely 50% with abnormal karyotype. If we will further break it down, if you are to be asked, what is the most common genetic defect that would cause your spontaneous abortion, and what should your answer be according to this slide?
Trisomy po.
So you would say most common defect would be trisomy 50 to 60%. So if you would go to percentage, if you're 50% with abnormal karyotype and trisomy is around 50 to 60%, that's more or less 25% abortion that would be caused by trisomy. Okay, so know your 50% abnormal karyotype, that's genetic. So, and if you will further break it down, if it's genetic, it's almost always early, okay? And it's almost always due to your maternal gametogenesis errors, okay? So that would most probably be elderly age, etc., etc. Okay? So with this slide alone, there are a lot of concepts that you should know and not limited to the previous question. So this would be cost answers, risk answers, and that is how you are able to answer these types of questions. Okay. Again, your infections, your 50% could be accounted for different etiologies. Top of it would be infection. Maternal disorders, of course, that would be your hypertension, diabetes, etc. Cancer, surgical procedures, nutrition, and other socioeconomic factors. Okay. Abortion could also be classified as according to their stage in when it occurs. So when would late abortion be classified? How many weeks age of gestation? Tatawag ba ako nung nasa screen ko? Joshua Carduque, how many weeks should you be in for you to be able to classify your patient as having a late abortion?
12 po.
At 12 weeks. This would matter in management. That's why it's important. What happens when you have 12 weeks? How would you describe the development of your fetus at 12 weeks? Thereby affecting your management, whether you would do an outright curettage or you would wait for spontaneous expulsion of your fetal products, then do curettage. What is the reason why for late abortion, what is our management? Would you do curettage outright or will you wait for spontaneous expulsion? Next na lang. Sumagot na si Joshua. Francis Clavillas.
14, Doc.
Sagot na yun, Francis. 12 ang sagot. My
Ay,
next question is, delayed ka ba? My next question is, how will you manage late abortion? Will you do spontaneous, will you wait for spontaneous expulsion or will you do a curettage outright? And what is the reason behind that?
Try lang po.
Karen?
Expectant po kasi at more than 12 weeks or late abortion, yung bony parts po ng fetus can lacerate the uterus. So, hindi po ginagawa yung curettage.
Okay. By 12 weeks, your fetal bones will be developed. such that when you do your outright curettage, you could have your complication of uterine perforation because there are skeletal elements already. Hence, we wait for spontaneous expulsion of the fetus before we do curettage. Less than that, we could do outright curettage or medical curettage for that matter. Okay? Okay. As mentioned, classification is early, less than 12 weeks, late is more than 12 weeks. Other classification, once you make your diagnosis, is either non-septic and non-induced. So you could classify it if it's an um, infectious process due to infection, or if um, your abortion is induced or not. Okay. So next question. So you are to be asked what kind of abortion is this, with the definition or with the description of the cervix, the fetal heart tones, and the size of the corpus. So you are expected to know how to classify types of abortion according to these physical examinations. So what type of abortion would have a cervix closed with fetal heart tones and enlarged to age of gestation?
Threatened po ba?
So you would have threatened abortion. Missed would mean the baby is already dead, so no fetal heart tones. Of course, your complete is closed, but would have an age of gestation that would have a corpus small. And your incomplete abortion would have your cervix, which is open. Okay. Same way, so I think I got ahead of my slide. So this one asks for, one, you should have to know how to compute for your age of gestation for you to be able to answer this question. So that is an OB1 skill. And this is a two-step question. You have to know your LMP or your AOG. For your March 2021, what is your age of gestation? Someone compute. What's your AOG? Megumi.
Hanggang ngayong date po,
Hanggang ngayong date,
mga 13 weeks.
hindi na nag-compute ha, mga 13 weeks. Okay. So, knowing that the patient is more than 12 weeks, what is your best plan of management? As I have mentioned in the previous slides, more than 12 weeks, what is your management? So how do you manage late abortion as mentioned?
Spontaneous fetal expulsion.
Await spontaneous fetal expulsion. So you know DNC is for your less than 12 weeks. Suction curettage is for your HMO. Expectant management would be for your for delivery or already passed out or already resolving abortion cases. Okay. So management of your abortion cases would be three-pronged. So it could be medical. So most would give your ergometrin derivatives. So that is your medical curettage. Okay? My take home point for you is not every abortion case would warrant a dilation and curettage. Okay? If after your passage of meaty material, your retained products of conception will be minimal, you could give your medical management such that you would not have to do a curettage, because curettage should also have your different risks, which we will go on later. Surgical, you have your DNC. If you do not want, there's also a procedure called vacuum aspiration. And expectant would be your spontaneous expulsion of your fetus, then curettage. Okay. So leading, you have to know the complications. So what is overzealous curettage? What does it lead to? John Carl Prado, what does overzealous curettage lead to?
Asher bands po, Doc.
So your Asherman. What is Sheehan's?
Yung sa
Hemorrhage.
hemorrhage po cause nung sa pituitary.
Okay. Excessive hemorrhage causing a dysfunction of your pituitary gland. Okay. Of course, your uterine perforation would be the other complication um, of your curettage, basically because of skeletal elements. And your endometritis, if you do not evacuate properly, and it would lead to infection, your retained products of conception could lead to a possible sequela of your endometritis. Okay? Okay. So complications, as mentioned, would be the following. Okay. So this would be a table regarding your classification, and it lists your threatened and missed, your inevitable, incomplete, and complete. The other one would be your habitual and, or your recurrent abortion, which is often immunological in case, and your induced classification. But this one, threatened, inevitable, incomplete, complete, and missed, you could differentiate through, as we have mentioned, cervix, size of your corpus, um, the bag of water. So you could, and your fetal heart tones. So this is a table. This is a nice table wherein you could see how it is different and how it is managed differently among the 5 common types of abortion. Okay, so study this table, and it would be helpful for you in answering the type of question mentioned prior. In what kind of abortion? So it could be a case vignette given to you, and it would not be directly at cervix closed, fetal heart tones like this, etc., etc. So, but for these questions, you have to know how to compute your age of gestation. All right. So, going to your ectopic pregnancy. So, for abortion, you have to know your definition, you have to know the risk, and of course your epidemiology, your classifications, your complications, and the procedure. Okay. For ectopic, so which is not included in the triad for early pregnancy disorders. What is the triad? Sino ba? Mau. Maureen.
Doc, except dysmenorrhea po.
Louder, please. What's the answer?
Except dysmenorrhea po.
Except dysmenorrhea. Okay. Except dysmenorrhea because we know that the triad would be the following of ectopic or your early vaginal bleeding disorders would be amenorrhea, abdominal pain, vaginal bleeding. Of course, we know that in ectopic, it is the pain is the one that is more pronounced. Okay. Favorite question, be it in the boards, etc., or your ectopic exams would be sites of your ectopic pregnancy. And what is the answer for this one? Is it the ampulla, isthmus, infundibulum, or fimbriae?
Ampulla po.
So,
Ampulla po.
okay. So you know that the sites of the most common would be tubal, would be 95 to 96%. Among that, your ampulla would comprise 70% of your 95%. And your others would be your isthmus, fimbriae, and ovarian. Okay? So most common, your ampulla because it's the narrowest portion. Okay? So you have to know your risk factors. So your previous tubal surgery, previous ectopic, PID, artificial reproductive technology, and contraception. So knowing that, what is the risk for a previous ectopic to have an ectopic pregnancy for her next pregnancy? So listed in the previous slide, it is 5 times the risk for a person who has had a previous ectopic for her next pregnancy. Okay. So shoulder pain occurs because this is more anatomy.
Si po yata, Doc.
Hindi ko siyata, diaphragmatic irritation. And you have to know the pathophysiology of your ectopic pregnancy to know this. And what is the pathophysiology of your ectopic which would cause your diaphragmatic diaphragmatic pain? Okay? So this is this is the pathophysiology of your ectopic. Then your zygote goes to the wall. So it proliferates. So it goes bigger in your fallopian tube, opens your vessels, and then it would lead to hemorrhage. This hemorrhage, would then cause irritation to your diaphragm. Through what nerve? Through what nerve? And this is also a common cause of that shoulder pain whenever you have your abdominal occurrences. It occurs, be it your appendix, etc., etc. What gets irritated? What nerve? Which has an insertion to your shoulder? Anyone?
Phrenic po ba, Dok?
So it's the phrenic nerve. Okay? So that's what that is the nerve which is irritated, thereby causing your diaphragmatic irritation. Okay. So this test is to exclude hemoperitoneum without the benefit of ultrasound. So of course we know ectopic pregnancy diagnosis, we see it earlier because of ultrasound. Okay, it's a very helpful diagnostic tool that drastically reduce the mortality and morbidity of ectopic pregnancies. But how, for example, if you are thinking of ectopic but you do not have an ultrasound at hand, what could you do?
Coldosynthesis, Doc.
What is photosynthesis? We'll go back to that later. So, discriminatory level of gestational sac should be detectable by ultrasound. I know these values vary from book to book, but in general, what is the range that we use?
Letter C po ba, Doc?
1.5 to 2,000. Okay, so if you are going to choose, because your 1.5 is also here, you choose the range that is between 1.5 to 2,000 around. Okay, so your value changes, it will be depending on your reference used. Okay, so these two questions ask how your ectopic pregnancy is diagnosed. So it could be diagnosed in a different number of ways. Of course, most common would be your beta HCG. So in the urine, it's 20 to 25 ml. In serum, it's less than 5. Of course, your discriminatory level is 1.5 to 2,000 milli-international units per ml. Your transvaginal ultrasound would show the following. Of course, your adnexal mass, which is distinct from your ovary, and your trilaminar endometrial pattern, meaning there would be no intrauterine gestational sac. Okay. But for example, if you have an adnexal mass and you have a if you have a gestational sac within the uterus, what kind of pregnancy do you call that? So you have an ectopic, you also have your intrauterine gestation, that's your heterotopic pregnancy, which is quite rare. Okay, nice to know at this point. Okay, your serum progesterone, more than 25, more or less excludes your ectopic pregnancy. Although if it's less than 25, it does not necessarily mean that you have an ectopic. Thereby use in clinical practice is quite limited. And our example where hemoperitoneum, you will see it in ultrasound and you will see it in your codesynthesis. Okay, you get a syringe and you get into your retroperitoneal sac, and if you draw blood, of course, if there's bleeding there and it will pull there, you will have more or less a diagnosis. You could um, rule in the possibility of an ectopic pregnancy. Okay. So, gold standard treatment for unruptured ectopic pregnancy is what? So, you think unruptured, you think ectopic pregnancy, what is the standard?
Self-ingotomy po.
What's the difference between your salpingotomy and salpingostomy and salpingectomy? So you have to know these things for you to be able to answer this question. Salpingotomy. What is salpingotomy? How do you describe salpingotomy as a procedure?
Pag salpingotomy po, Doc, yun po yung ini-incise yung fallopian tube tapos sinusuture po after ng evacuation. While yung salpingostomy po, hindi na po siya isusuture. So, healing by secondary intention na lang po.
Gusto mo nang tapusin? What is salpingectomy?
Removal na po ng fallopian tube.
Okay. So for the fallopian tube defenders or your reproendo, what is their preferred procedure? So not even for your general obstetricians, what's the procedure of choice when you are to do unruptured ectopic pregnancy? So it's the procedure with the least trauma to your fallopian tubes to increase the risk of to decrease the risk of another ectopic pregnancy. And the least trauma among these three procedures, okay, save for your medical management, would be your salpingostomy. Okay. Your medical management would have criteria for us to be able to say that it is eligible for medical management. But for unruptured ectopic pregnancy, you do your salpingostomy. Okay. So, methotrexate can be used if I forgot um to unbold the correct answer. So the gestation is less than 6 weeks. Okay, so for you to be able to answer these treatment questions, you have to familiarize yourselves. You have to familiarize yourselves with this table of treatment. Okay, this one's medical management, this one is your surgical. So, patient is hemodynamically stable. For you to be able to use your medical management, your age of gestation should be 6 weeks. Your tubal mass should be less than 3.5 centimeters in diameter. Your beta HCG is less than 15,000 and there is no detected fetal heartbeat. On the other hand, if it does not fulfill this criteria, your procedure of choice would be your laparoscopy, especially for ruptured ectopic pregnancies. And of course, when your medical therapy is contraindicated or if your patient refuses your medical management. So for medical management, we use methotrexate. Okay. You're using methotrexate and if you find out that it's toxic or above normal therapeutic levels, what is the antidote for your methotrexate? What's the antidote for your methotrexate?
Eucoverin po, Doc.
Okay, your antidote is your leucovorin to combat your methotrexate toxicity. Okay. Of course, you have to monitor your serial post your baseline and your serial post-treatment serum beta HCG. Okay, nice to know at your level, but you measure it on day 4, then day 7 after administering your methotrexate. Most commonly used would be the single dose regimen um, that you give to your ectopic pregnancy patient. Okay. On the other hand, if your patient is for surgery, so exploratory laparotomy is indicated. Okay. It could be salpingostomy, as mentioned, salpingectomy, or salpingotomy. Of course, another becoming the gold standard, although prohibitive because of cost, would be your video laparoscopy. So more often it is like the conditions are like your medical management. It has limitations in size. It should be unruptured. Your patient should be hemodynamically stable for you to able to offer your patient your video laparoscopy. So you are using just 3 incision points, and you remove the ectopic pregnancy using your trocars, and thereby lessening, of course, the ultimate goal for that procedure would be to reduce the tissue trauma experienced by an open by an exploratory laparotomy procedure. Okay, so for ectopic pregnancy, again, definition, risk, risk factors, your treatment, how you manage, you should know. So those are the must knows for this topic, ectopic and abortion. Okay. So for your seminar, so with the variety of topics that you have to know, you have, for example, per topic, you would just have 3 to 5 questions per topic. So at least the must knows you know at the back of your hand, so that of course your exam would throw in some difficult questions that would vary, questions that would vary in difficulty, but at least the must knows you would know, you would have to know at the back of your head. All right, any questions?
Wala naman po yata, Doc.
Wala? Okay. Good luck with your seminar exam. It's the second to the last, right? Seminar that you would have. I think we will have PrevMed next week. But think of your obstetrics and gynecology first before you think of your PrevMed. All right? Good luck in your
Hindi po,
exam.
Doc.
If you want to
Thank you po,
review,
Doc.
or if some of your classmates missed the review, you could go to the channel and it is posted there. Good luck.
Okay
Thank